Got it. Okay, excellent. So all right, so it started recording, right?
Yes.
Okay. So I think we can start now. Yeah. All right, excellent. So just a second. Sorry about that. Just a second. I'm just trying to share the screen, but it all went down. 1 second. All right. So I'm just going to share screen now. Okay. All right. So we're going to start now. Okay. So we'll take it. I hope this is clear for you. As I said, I will be covering a lot of questions, especially those that come on the USMLEs. And the Canadian exams and USMLEs are very similar. So is the PLABs. I'm going to give you a brief overview on CTs to start with. And then afterwards, we're going to be tackling questions. Okay. So just a second. Oh my goodness, where did I go? Yeah. I'm just going to start a slideshow now. I hope it works. Acting funny today. Anyways. All right. So here we go. First of all, I think somebody needs to mute us. Somebody needs to mute us. Anyway, so this is what we will be covering today. We're not just going to be covering brain hemorrhages, infectious processes, hydrocephalus, dementia, tumors, only the high yields that come up on your exams. And I'll also be giving you some tricks during your ward rotations that will help you out. First of all, just a brief overview. I don't want you to get out of my lecture just knowing high yield stuff. You need to know some backup about this topic. I also wanted to mention, first of all, we're going to start with the CT head brain. It's a big topic. As you can tell, we've got hemorrhages, infections, tumors, dementia, so to cover, and these are heavily tested on, especially in your, let's say, Western examinations. So if we have time, we can move on. But for me, I would like you to come out of here being a professional when it comes to the CT brain. If we don't have time, the next lecture will be about CT mediastinum and CT chest. These are very brief. There are some discrete questions that come on your exams, not too many. And there isn't much teaching because it's very brief, it's very small, please. So first of all, whoever is, yeah, please just mute us if you're not muted. You have to know X-ray, CT, radiation, MRI, no radiation. This is a moral obligation for all of us as doctors, regardless of your, let's say, specialty, because basically the more CTs you order, you have to bear in mind that you are subjecting them to further radiation. This has teratogenicity, this has increased oncologic complications, and it bears a huge weight. So always remember that, okay? Always remember that. Let's go to the next one. When it comes to CT, and for me in the wards, especially as an intern, especially as a student, I was always asked, for example, describe this finding, okay? And when it comes to CT, please do not get it wrong. Hyperdense, hypodense. And there's a huge difference between CTs and, let's say, X-rays and MRIs. I'll mention them briefly, but don't come out of my lecture not knowing, number one, CT is radiation. Number two, we describe it with density. Hyper means white. Hypo means black. Hypo, low. Hypo, low. So decreased, low attenuation. And always use density. I see a hyperdense lesion in the right frontal lobe, for example. Perfect. Your mentor, whichever country you're rotating in, will be very proud. So I know this image is blurry, but I did my best in order to procure at least a slide to help you understand the orientation. Whenever you look at a CT image, there is a right. The right is on your left and the left is on your right. Just like, for example, the X-ray, for example. Why I'm saying that is, first of all, I memorized it, but then I found myself, for example, on post-call days, on whatever those tired days, I would forget it. So I decided, hey, I want to understand it. When you put the patient in this position, in this sleeping position, basically what you're doing is look at his head. His right is your left. You're looking at him from his feet. You're standing at his feet right now. So his right side is your left. This is my left hand. And his left brain is your right. So whenever you look at a CT image, the right, for example, the left side is the right and the right is left. Okay, so my right hand is equal to the left side of the brain. And the same goes. My left hand is pointing to the right side because I'm standing at the foot of the patient, and the cut is coming like this, exactly like the image. If you didn't understand, you can ask me at the end of the lecture. I don't mind explaining. Okay, so why I put this picture? Because I just explained hyper and hypo densities. Okay, so for example, when we say hypo, I said low, black, decreased attenuation. And when I say hyper means increased attenuation, okay? And this is a very nice classical example of what we call a subdural hematoma. But you can tell that there's a difference. There's a hyper and hypo, and I'll explain it. You will come out of this lecture, you will see it, you'll answer it, and you'll go to sleep straight away. It's gonna be very, let's say, it's gonna be very easy for you to understand it. Why? What I want you to take home from this slide exactly is, first of all, you have a hyperdense, means it's acute. And the chronic one, chronic means it's been there for a long time, is usually hypodense when it comes to hemorrhages, okay? Ischemia is usually always hypodense. So you can have these two. For example, Muhammad Ali, the boxer. A lot of boxers, alcoholics, elderly with dementia, for example, elderly patients with dementia, they tend to have repetitive subdural hematomas. And so you have a chronic one, and then you have acute on top of a chronic. So he has a bleed, he goes home, he recovers, and then he goes into another boxing match, he has another bleed. That's acute on top of chronic. But acute bleeds, hemorrhages, are usually white. Older bleeds are usually black, hypodense. This is another example. That's what I'm saying. I just want you to familiarize, because CT images is you going over and over and over. This is like a crash course, okay, guys? So it's you going over and over and over these CTs in order to basically get your eyes accustomed to it. So other namings, don't forget, whenever you want to explain, for example, pleural effusion in an X-ray, there's a radio-opaque. Let's say there's an radio-opaque lesion in the, let's say, occupying the, let's say, left lower lung with obliteration of the costophrenic angle. This is the most perfect pleural effusion description. I said radio-opaque. Radiolucent, for example, when you have emphysema, increased lucency, right? Because hyperinflated chest, more air. So radiolucent, radio-opaque. That's how it goes. When it comes to MRI, intensity, hyper and hypo intense. And with CT, it's density. This is me like, I mean, nobody will put it to you like this. I had to actually search it to put it in one slide. So always remember, density is with CTs. Always remember that, please. Okay, next. So, for example, if you see this image and you are the only one covering the ER, and this image comes up, oh my God, a traffic accident. Okay, you have to be able to delineate. There's a hyperdense lesion, and we said my left is there, right? So on the right, let's say temporoparietal or temporoparietal occipital lesion. Let's to keep it simple, okay? So you have to know quick. It could be a hemorrhage, or it could be a larger tumor or a bleeding tumor, for example, or calcifications, but they are much smaller, the calcifications. So you have to have a differential of hyperdensity. Real quick, you have to act fast. When it comes to hypodensity, the most important thing that we care about and you will be tested on is the ischemia. Now, bear in mind, sometimes you can have, for example, infarction or a stroke and edema around it. Please mute yourself. So the second one is, as I said, ischemia, and sometimes you have surrounding edema with whatever, let's say, pathology that you can have, which will appear black as well. These are the most important ones that you need to know, and the ones that you need to diagnose, especially during your medical rotations as a doctor as well. So you can tell the difference between hyperdensity and hypodensity. Hypo, low, okay? Ischemia should be at the top of your differentials. Hemorrhage should be at the top of your differentials with hyperdensity. Hemorrhage means, I know this is easy for a lot of you, but it's good to reiterate. Hemorrhage is a bleeding vessel. It's like open and it's bleeding, okay? Whereas, what's it called? Ischemia, there is decreased blood flow. So basically this leads to ischemia and necrosis. So it's like dying out. So we're used to, for example, let's say when we say toe gangrene or ischemia of the digits, they turn black eventually, right? This is exactly what's happening. Just like a toe gangrene, when it turns black from prolonged ischemia, it turns black. The brain also turns black on CT. This is one way to remember it, okay? So hypodensity, it's black. Okay, toe gangrene is also black. There is ischemia, okay? So that's, I mean, not bleeding. That's one way I remember it. Okay, so I would like to discuss this classic scenario. We still did not go into the crash course questions yet, because I don't want you to come out of my lecture being just a student who memorizes questions. I want you to be a good clinician, because it's my moral obligation as well. There are 2 or 3 more slides, and we will go into our crash course. Basically, this is a classical scenario. You will not spend a single on-call without meeting this. 75-year-old gentleman, okay, chronic smoker, diabetic, hypertensive, ischemic heart disease, altered level of consciousness, and neurological deficit. So, I mean, the doctor here ordered contrast CT. Is this right? Okay, I won't be expecting any answers from you guys. I know how stressful it can get. But for me, what I'm trying to point out is, I'm guessing a lot of you are looking like that. That's why I don't like pointing out. The answer is no. Now, if you are suspecting any form of, for example, ischemia, or you're suspecting any form of any neurological involvement, a central lesion, patient comes with neurological deficit, elderly, multiple comorbidities, and he's just either unconscious or he's not moving some side of his body. First thing to do, even if it was ischemia, first thing to do is never give contrast CT. Never give contrast CT. Always use non-contrast. Okay, Dr. Sam, why are we using non-contrast CT? What's the point? Because hemorrhagic bleeds, they appear white. And the contrast, if I give it, it can appear white. So it can give me a false impression that I'm dealing with a hemorrhage, when in fact there isn't any hemorrhage, it's just a contrast. So it will obscure everything. So anytime you get a similar scenario with neurological deficit, opt for non-contrast CT. And then when we rule out hemorrhage, because in the non-contrast CT, if I don't use contrast, there will be white, and I will know it's not the contrast, I didn't use contrast. I will know this was purely the bleed if it was there, okay? So anytime the person has that, use non-contrast CT, no hemorrhage, then we can start the stroke protocol, okay? So let's get into it. Now you've got to keep your eyes open, and let's see how I can teach you these. Now, these are examples of super high yield stuff that will come on your exam. So you will not graduate from med school, and you will not sit a single Western exam without being subjected to one of the following that I will be viewing for you. This is epidural hematoma. Epi is Greek or Latin, let's say on top, okay? For me, how I remember epi, literally, how Dr. Sam does, I'm an internist, I still remember it that way. On top, I just remember it like Mr. Joe here. Mr. Joe has a belly on top of his abdomen. So epi literally means on top. So you have sort of like a belly coming up in this brain. It looks like a belly, like it's building up, it's building forward, you know, just like Mr. Jeff here. So whenever you see like a protrusion, okay, similar in fashion to this on top, like epi, this is like an epidural hematoma. You should not miss it, okay? So if I were you, I'd take pictures of this as I go, and then tomorrow, anytime you have a 5-minute break, anytime you have, let's say, what I want to say, anytime you have a break between in the bus, going home, going out, just go through it, just like that. So these are high yield questions. I'm sorry, this picture is obscuring the question. Anyways, what is your diagnosis? These are the 3 most important questions I have certainly been subjected to in almost all Western examinations. What is your diagnosis? This might come up. Or what is the afflicted vessel? Middle meningeal artery, guys, MMA. Okay, because they can say middle meningeal vein. They can put the bridging veins. They can say congenital rupture of berry aneurysm. Okay, guys. So please, please, please just remember it that way. And a lot of the causes of epidural hemorrhages are from trauma, RTA, fighting, all of that. I have seen a lot of this. The third question, what is the location of such bleed? They will put dura skull, dura arachnoid, arachnoid pia, so they will confuse you. I just want you to know, epi means on top, okay? And what I want you to know is it's between the skull and the layer of the brain, the dura, okay, the outermost layer of the meninges, okay? So it's between that space. So it's the outermost of the options, okay? Always remember that. These are super high yield. If I were you, I'd take a picture. So this is how I remember it. MMA, I said middle meningeal artery. Most of the guys probably are familiar with the MMA fighting, okay? And look at this guy. He's literally going all the way to the temporal bone, and it's actually where the MMA can actually be found, somewhere around that. And I chose this precisely because if this guy kicked him a little bit harder, he will end up with epidural bleed. This is just an epidural hematoma waiting to happen. MMA right here, epidural, okay? MMA, mixed martial arts, huh? Okay, subdural hematoma. Subdural hematoma looks like a crescent. I'm not sure, I can't point, I can't use a pointer, but, oh, here it is. Here it goes. You can see over here, this dark part, this looks like a crescent, more of a moon. Okay, so this is a subdural hematoma. Okay, big difference between it and the epidural hematoma. Looks like on top, like a belly, like the brain has a belly of its own. And this one, which looks like a brain, is going inside, as opposed to the epidural, which is going out towards the outside. Okay. Whoever is not muted, please mute them, or please get muted. Okay, so let's go with the questions. What is your diagnosis? This could be one of your OSCE questions, or for example, it could be like a question that can occur in the written exams. Highly probable. Which vessel? This is like, if I'm going to choose a jackpot question, it would be this one. They'll put the CT and tell you which vessel. They expect you to know what hematoma we're dealing with. Is it subdural, epidural? And then they'll expect you to answer the vessel sida, ala طول, okay? And then where is the location? Now, if the examiner is having a bad day and he put those not so nice questions, they will ask you, where is the lesion located? Very important, guys. Take a picture of this one. Where is the lesion located? Between the dura mater and the arachnoid layer. They will confuse you between dura and skull, which was what we discussed with epidural, or dura and arachnoid, or they can mix it up, dura and pia, it doesn't even make sense, or between arachnoid and pia matter. So make sure you are aware of these, because these are very, very, very important. And these are essentially the ones that you get asked on. I just don't want you to just be good examiners. I also want you to be good clinicians. So I hope I was able to deliver the information. Now, subarachnoid hemorrhage, they love it, especially the West, because they get a lot of those hemorrhages, unfortunately. So you will be tested on just as much as you will be tested on cystic fibrosis. So what I'm trying to say, or what I'm trying to show you here, I put a diagrammatic representation, because for me, when I was a student, it never made sense. I'm just memorizing this, spider-like, web-like appearance. But actually, how I understood it is through this image. This image showed me that there's bleeding in the cisterns, as you can see here. There's a blood trail, which will parallel or be mirrored onto the CT. Okay. So there's bleeding to the cistern right into it. So it's going into it. Okay. And this is what you expect in subarachnoid hemorrhage. Extremely different from the epidural, Mr. Jeff, and the subdural, which is like the crescent moon shaped, like gives me Ramadan vibes. And then we have the subarachnoid hemorrhage, which is bleeding into the cistern. It's like going inside. The subarachnoid, it's going to kill you. It's going to go inside and it's never going to come out. Okay, that's what it likes to do. So, oh, yeah, that's how I imagine all of you are looking like right now. I understand, but these are very important questions. If you have a test on test day, you didn't have a chance to go through these hemorrhages, take a capture of all these that I have just uploaded and just go through them. Anytime you have a 5-minute break, as I said, in the bus, in the taxi, whatever, just go through them. What is the diagnosis? It could happen if the examiner is having a good mood. But what is the afflicted vessel? Usually arteries of the circle of Willis. The commonest cause, now surgeons will love this, trauma. And the second commonest cause is congenital rupture of Barry aneurysm. Okay. What is the classical symptom? They will tell you the patient, I mean, you're reading, let's say, you're doing the Canadian or the USMLE, and you're reading through the 17-line USMLE Step 2 CK question stem, and you have no time, you have 1 minute, and then you see worst headache of her life, occipital headache, worst headache. And then they see attached is a CT image. And then you click it, it's final. This is subarachnoid hemorrhage. Okay, where's the location of the bleed? I have seen this, okay, between the arachnoid and the pia. Please, guys, make sure you memorize this. Make sure you know it very well. And there's a little bit of a surprise also for you, actually after this one. What is the diagnostic modality? Brain CT, this is a given, guys. They will usually not ask brain CT. They will ask the next question. Now, what if the brain CT with a subarachnoid hemorrhage was negative, but you as a physician, you still have very strong clinical suspicion that it is subarachnoid hemorrhage. And actually this happens a lot. What you do next is what we call lumbar puncture, okay? And we look for xanthochromagia, which is basically, there will be discoloration. What's gonna happen? If there is actually bleed, when you pull out the lumbar puncture, you have to understand it. Xantho means color in Latin. Yellow coloration, and yellow, and chromagia means color. So yellow color, yellow discoloration, xanthochromagia. Why I'm saying that, guys? Because I have been asked like this during med school, not so much my Western examination, but you have to understand, if you're still suspecting the patient to have subarachnoid hemorrhage, LP him or her. And then what's going to happen is the answer should be looking for xanthochromagia. If there is in fact a bleed, what's going to happen is the red blood cells within the sample of the LP will lyse, and they will release the hemoglobin and the iron. So you will have, and the bilirubin. So you will have yellowish discoloration. That hence the name xanthochromagia. Okay, just understand it. There's blood, breaks down. I have discoloration. This is subarachnoid. This is my second. Usually, if they're going to ask you about the diagnostic modality of the subarachnoid, it will be this one. What is your, if you have a strong clinical suspicion, LP. I have placed this to remind you guys that do not think of going into any USMLE examination, or don't even attempt to do it if you did not memorize the circle of Willis. I'm serious. They want you to know it precisely, okay? And it will take you 5 minutes. I know it looks like, well, not too much, but if you break it down, it's pretty sweet actually. Okay, so these are the internal carotids over here, and then we have the MCAs on each side. Don't forget that. And then we have the ACA, which usually we said the ACA gives you lower. I mean, this is, we're going into neuro, but MCA gives you upper, and the ACA gives you lower symptoms, right? And then we said we have the anterior. I don't want to go through these. I just want you to know that. Just take a picture of it, break it down, and it will be very easy. 2 vertebral arteries give you a basilar. See, now we finished a third of it. Okay, so just do that because first of all, it's good for your clinical knowledge. Number 2, it would be a shame if you lost a question and they asked you where is the side. If a patient, for example, I know this is not CT related, but if a patient, for example, presents with neurological deficit that is mostly upper more than lower, and they will tell you, please point at this. You have to look for the MCA. If you lost the point, it's right here. If you lost the point, it would be a shame actually. So unfortunately, this important is obscuring it, but this is what I want. This is lobar hemorrhage. And since in the West, amyloidosis is very, let's say, more common than, for example, the Middle East, they will care about their patients and they will want to make sure that their upcoming doctors know about it. Do not miss this. This is what we call amyloid angiopathy, lobar hemorrhage. Lobar, I'm sorry about the that sticker over there, important sticker. It is important, but I wanted it to come out. But lobar hemorrhage, amyloid angiopathy, if you see amyloid, you tick it, you move on, and you pray for Dr. Sam in the remaining time during your exam. Okay, this is how I'm going to look like, honestly. Okay, if you get lobar hemorrhage, lobar amyloid angiopathy wrong, I guarantee you it's coming. Okay, so we're going to go into the infectious processes. And here we have the ring enhancing lesions. Now, why I wanted to bring this up, because it is very important. It shows up in nearly every exam, medical exam. I want you to get used to ring enhancing lesions. A lot of people will take a look at this and think this is metastasis. It's not. They want you to think that, because a lot, like let's say 25% of the test takers will think this is quite blandly metastasis, when it's not. It's a shame that 25% would think of that. Just get your eyes through it. This is what we call ring enhancing lesion. And now I have produced a very nice, let's say, technique. Simply, when you are, when a large question stem is thrown at your face, and you're expected to answer it in 1 minute, and then the question stem says multiple ring enhancing lesions, you have to think toxoplasma or lymphoma, brain lymphoma. By the way, they ask brain lymphoma, usually secondary to EBV. This is not related to the CT, but I'm giving you free points here. Okay, so usually brain lymphomas are secondary to EBV. So they can ask you, for example, what is the virus? Or they can ask you brain lymphoma. Or we have toxoplasmosis. And usually they will give you more symptoms to go with toxoplasmosis. So don't worry so much about it. But there will be metastasis. There will be, for example, calcifications. You will also be you'll see neurocystic sarcosis. You will be seeing all of this. You're like, okay, I don't know where to start. The moment I see single ring enhancing lesion, I choose tinea solium. I don't even think twice. Okay. For our level, we're still all like juniors at the end of the day. You have to think fast, okay? Fast response. So don't forget, ring enhancing lesions, multiple are either toxoplasma or what we call the lymphoma. And single is tinea solium. I will not forgive any of you if you forgot this, because it actually took me some time to actually learn it and then, you know, put this in my mind. And actually, I'm thankful for it. So, yeah. So normal pressure hydrocephalus, when you see that there is let's say, for example, a ventricular enlargement out of proportion to the brain dimensions and without any sulcal dilatation. So it's just the dilated part is only the ventricles, and everything else looks nice, everything else looks good. You have to immediately think normal pressure hydrocephalus. Now, of course, I understand this is hard. I'm not giving you any clinical symptoms, but now I will be. But it would be much better if you were able to see it and then, you know, be able to basically, once you see the image, okay, I'm thinking NPH, and then once I read the question stem, okay, it goes with NPH. Okay, we have the triad: wobbly, wacky, and wet. So a patient comes with confusion, dementia, memory loss, and unstable gait, and urinary incontinence. Usually it starts with urgency. This triad you cannot miss. This is 3 marks on your exam. This is like, you know, just telling you, just pass, please. So wobbly, wacky, and wet. Okay. Now I like to take it a little bit overboard, so as to make it you know, on all over a crash course. A temporary treatment of the NPH will be LP. And if you were ever told that, for example, that a patient who with urinary incontinence and gait instability, a little bit of memory impairment, that's it, okay, comes with the similar CT that I showed you, and improved minutely or minorly with LP, please think of NPH. You should have a working diagnosis of NPH if you're a patient in the hospital setting, or when we say it in, for example, in examination settings. Of course, I would like to annotate that the permanent treatment for it is definitely the shunt. Okay, so ventricular peritoneal shunt. Okay, so usually it's elderly, usually it's idiopathic. There's really most of the times it's idiopathic, so there's really nothing you can reverse. There's no cause to reverse, but you can, you know, try to decrease the complications of it. Okay, all right. I don't know why it's going on to the left. I apologize, but we're going to go. We have reached nearly the towards the end of the lecture, but we have a few slides that I want you to see because these ones pop up on the exam so many times. Now, glioblastoma multiforme, if you see an image like that, okay, butterfly shaped, you have to think crossing the midline, definitely glioblastoma multiforme, definitely. Now, this is a very brutal, this is a very, let's say, aggressive tumor, very poor prognosis. Because it's very brutal, it can cross the midline. It will not respect any boundaries. It will look like a butterfly. Number two, I'm just giving you quick and easy tips. Meningioma. Okay, how I remember meningiomas when I see them. There are too many tumors, guys. That's why I'm trying to put to give you some tactics to remember it. Meningioma comes from the meninges, right? So when I say it's coming from the meninges, look at it. Look at how it's like a protrusion of the meninges. It's stuck to the wall. It's not coming from inside like the glioblastoma. It comes from the inside and spreads like a butterfly. No, it's coming from the wall. Like there's like a protrusion from the meninges themselves. Okay. So whenever you see a tumor and they show you this picture, it's coming from the meninges, like a protrusion from the brain itself. Think meningioma. It will always look like this. It has to come from the meninges. It will never come from the center. Okay. This is an MRI. I know this is a CT picture, but it would not be complete if I did not talk about pituitary adenomas. Very important to know where the pituitary is located, not just during your test. When treating your endocrine patients, you will have to resort to MRIs of pituitary. A patient has prolactinoma, growth hormone producing adenoma, etc. You have to know what you're looking at, okay? And this is the exact place for the let's say pituitary. And do not be surprised, you will be asked. Exactly, they will label, for example, see the area where it says brain, and then over here, and then over here, and then over here. So they will be labeling your brainstem, your cerebellum, and your, for example, pituitary. And then they will be telling you, okay, and your hypothalamus, for example, all of the entire area, this whole thing. And then they will tell you A, B, C, for example. And actually, that's good because you will be meeting a lot of this in your everyday, let's say, life. For that reason, I encourage you after this to be familiar with where the pituitary is located. This is a pituitary adenoma. There you go. Okay, so please just familiarize your eyesight with how it looks like. Very, very important to know. Okay. All right, so I'm going to move on after that. I think we'll just have a few slides left. That's why I brought metastasis, because they look like ring enhancing lesions. Okay, I made sure that brain mets are here. A common question, where is the location of the source of the metastasis? The commonest location is lung CA. Okay, guys, lung CA. Brain metastasis, multiple lesions, for example. Okay, we have multiple lesions. Looks like ring enhancing lesions, is not. They will be giving you a lot of, symptoms that go with, cachexia and stuff like that. And they will be giving you signs and symptoms of, they will give you signs and symptoms of, for example, the primary tumor, the lung CA, hemoptysis, etc. And then the patient was found to have this, for example. So lung CA usually is, how can I put it, is the most important source. So if you get asked that question, be sure to answer it. Okay, so now we have quiz time. So now we covered hemorrhages, we covered ischemia, we covered infectious processes, we covered dementia, mainly an NPS that you will come across. We also covered, I actually forgot what we covered. Yeah, the tumors as well. So now I'm just gonna quiz you like three slides. I'm not gonna expect any of you to basically answer because I know how you feel. Sometimes we all feel like this mouse, but whoever joined now or in the last 5 minutes, we recorded it, so don't worry about it. First of all, so I'm going to give you 5 seconds before I blurt out the answer. So this spot diagnosis, actually, guys, if you can see Mr. Jeff's belly here, then you made a good choice. So 5, 4, 3, epidural, okay, over here. I mean, I'm literally pointing at it, and I explained to you what happens with this process. I hope you were able to answer it. So this is subarachnoid. And here it looks like crescent, moon-shaped. This gives me, as I said, Ramadan vibes. This is most likely a subdural hematoma. Always think, by the way, don't miss out shaken baby syndrome, because let's not forget, most of our exams are incorporating a lot of aspects together, especially pediatrics. And shaken baby syndrome that you can have, if you can tell here, there's the acute one and there's a little bit of an element of a chronic one. This is one provisional diagnosis, doesn't mean it's 100% right, but if I saw this, I would think maybe a demented patient, repetitive fall, a boxer, shaken baby syndrome. When you shake the baby, you can end up causing or inflicting subdural hematoma. And if you keep doing it repetitive as a form, for example, of abuse, chronic repetitive subdural hematomas, that's also one thing they like to test you on. Repetitive subdural hematomas can come as old and new, hyper and hypo. So we say acute on top of chronic subdural. Okay, I think, yeah, this brings me towards the end of my lecture. It was a pleasure actually being here. As I said, I don't want to bombard you with too much information. We can definitely discuss the mediastinal CT and the abdominal CT with questions and high yield answers and then in the next time if you guys desire it. As I said, I also would like to thank Kumse UK for this opportunity, and I also would like to share with you my accounts. I have already included these similar high yield tumors with more elaboration actually over here. And also when it comes to the bleeds, I have several posts when it comes to that. So if you'd like to, you can take a look at it. I would like to thank you very much for being here. And if you guys have any questions, I'll be more than happy to answer them. If not, then I'll be more than happy to see you next time as well. So